everybody. Really glad that everybody can join us on the call. And we're really honored to have a couple of speakers here today to share their perspectives and thoughts on, come on in. A couple of live members walking in the room. To share their thoughts and perspectives on the linkages and relationships between health and climate change. And so without much further ado, I will introduce the speakers. First of all, Dr. Neil Maizlish is a research scientist at the California Department of Public Health, where he focuses on the public health impacts of climate change in the built environment, modeling health co-benefits of active transport, and the developing community health indicators. He has over 25 years of experience in quantitative research methods in local and state government, academia, community clinics, unions, and the private sector. Despite increasing specialization of epidemiologists, Dr. Maizlish is an unabashed generalist. Along with Dr. Maizlish, we have Brooke Sommerfeldt, who is a health program specialist at the California Department of Public Health in the Office of Health Equity. Her work includes developing health education and communications strategies to increase awareness of climate change as an important health issue and expand health-oriented climate action efforts in California. Prior to working at CDPH, Brooke was an instructor at San Francisco State University. She is an AmeriCorps alumni. Yay! Ms. Sommerfeldt has a BS in environmental science and earned her MPH at San Francisco State University. And I don't know if she's unabashed about anything. We'll find out.
Yeah,
so we'll turn it over to you guys, and thank you so much for coming.
Okay. Hi, this is Neil Maizlish, and it is a real pleasure to be here. Today we're going to do a primer in public health and climate change and have a very exciting activity as part of the overall program. So just to give you a heads up of what we're going to try to cover today, I'll give you a background in what is public health, what's its structure in California. Many of you are interacting with local governments, and you'll probably encounter local health departments and have a better idea of what that looks like. Also talk about what the existing burden of disease and injury is in California, to give the framing of what the health status of California is as we go into climate change, which will add to the burden of injury and illness over the next decades. We'll also talk a little bit about health inequities, which is part of the public health landscape. That when we talk about disadvantaged communities, there's also a health disadvantage that often accompanies that. And then we'll have our communications activity, which I think will be very engaging and a lot of fun. So without further ado, I'm going to start talking about what is public health. I'm making the assumption that many people have some vague idea of what public health is, so I'm going to give it a little bit more flesh. So there are many different formal definitions, but the one I like is it's the science and art of preventing disease and injury, prolonging a quality life, and promoting health through organized efforts of society. That contrasts with what many people think about public health, going to the doctor. In a way, that's, health care is what happens when you lose your health. So this is preventing people from getting sick or injured. So this is a different way of looking at it, and I'll give some of the accomplishments of public health over the last century, or actually in the 20th century, that will give you an idea of what this organized efforts means. So immunizations. When you look at the curve here on the right, this is the longevity, life expectancy at birth of the U.S. population from 1900 to year 2000. And you can see that, at the dawning of the 20th century, the life expectancy in the United States was like 45 years. You see a lot of variability. Some of that is actually infectious disease outbreaks. That one point that you see sort of off the chart, that was a combination of swine flu, which killed millions, and World War I. So a lot of that variability is that. After World War II, you see this this progression of the curve where incrementally it's improving. Then we'll point out that things like sulfa drugs and things that we think about of preventing people from dying from just simple operations and getting infections, that wasn't introduced until the 30s and 40s. So much of the public health improvement, that first 50% of the increase in life expectancy was really about improving living conditions. So people who are in the planning world and people who are in public health, we were joined at the hip in the 1900s, or early 1900s. It was very much, that sanitation movement was very much the same movement, politically, scientifically. So these are the things that improve health, and I'll talk a little bit more about the social determinants of health that gives a sort of a broader framing. But many of the things about motor vehicle safety, workplace safety, things as simple as child-proof medicine bottles. When you look at the poisoning rates, before and after those things were introduced, you see that there are certain things, again, as an organized entity. It's not just about the mom or the dad, keeping it high up on the medicine cabinet, but there's engineering solutions and other things that can be implemented that will have broad, long-lasting effects. So I don't want to dwell on this, but this is how we frame public health. It's an organized effort by society and local health departments. State health departments are very much part of that. In a way, we've been so successful where we're not worrying about communicable diseases and epidemics for the most part. Yes, we've had Ebola and we've had some outbreaks of measles lately, but we've been so successful, we're almost invisible. People don't even understand how successful we've been and how everyone's life has become so much more certain by these public health activities. So I just wanted to point that as just the basic framing. Now, in public health, we talk about the essential services that we provide as public health agencies. So I just want to talk a little bit about this and then show sort of what the relationship is between that and climate change as well. So, we monitor health. So we're collecting data and statistics all the time to see whether there's outbreaks occurring or not, or whether chronic disease rates are going up and down. That's part of, what we call public health surveillance. It's not, epidemiologists hiding out in bushes. It's actually collecting the data from healthcare facilities, from birth certificates, death certificates. That is the kind of information that we're collecting all the time, analyzing on an ongoing basis. When we see something that's unusual, then the next item is we investigate and we diagnose and then we try to intervene in some way for disease control. More broadly, we inform, we educate, and we empower. And part of why I'm here, and everyone in the room and everyone connected to the webinar today, this is part of my function. I'm doing it right this second, talking about this activity. There's many other things that we do in public health that I won't dwell on, but this I think should give you an idea that we organize our activities at the state level and at local health departments around these essential services. They include policy development, evaluation, and a bunch of other stuff as well. Now, let's see if this slide isn't oh boy, I have to go through each one. Okay. All right, we have a little bit of animation here, but there is a climate, yeah, when you get to that, there is a climate change corollary to each one, or virtually each one of these 10 essential services. So when we're talking about, and I'll just give one example to make the point, is that when we're talking about collecting data about the population health in the community and collecting cases of, it could be West Nile virus or some other kind of vector-borne disease, that's what we do. Climate change is going to likely change the temperature precipitation regimes in California and the distribution of the vectors that cause certain kinds of diseases, whether they're West Nile virus or other kinds of things like hantavirus or Lyme disease, things like that, or dengue. Those are the things that we already have some infrastructure in place and partners as well to be monitoring this. So each one of these essential services does have a corollary about how climate change is impacted. So I'm going to go on to the next slide. Just a sense now of how public health organizes itself from an official standpoint. In the state of California, there are local health jurisdictions that are officially recognized, which means that they get funding either from the state or from the Centers for Disease Control. So these are official entities. There's 58 counties, and there are 3 municipal health departments. Berkeley, Pasadena, and Long Beach have retained what in an earlier era were municipal health departments. But those cities, their city councils, their supervisors are supporting them as well. So there's local resources going into that. In order to set up shop as a local health department, you need a health officer and a director of nursing. That's part of statute. So there's many other parts of the health department, but officially that's all you need to be in business. And the health officer is almost always a physician. Health departments are sort of in business in a sense. They do generate a little bit of revenue on their own. They register births and deaths, and they charge a little bit for death certificates and birth certificates. So they have a little bit of revenue stream, but largely it is through state subsidization and federal subsidization that they get to do their myriad of programs. Just also to point out that there is a state law that requires physicians, laboratories, and healthcare facilities to report communicable diseases. And there's a list of about 40 particular diseases. They're mostly communicable diseases, pesticide illness. Heat illness is not one of them, but there are people who are interested in seeing, taking a look at that list from a climate change point of view. But anyway, there are disease reporters out in the community in physician offices, laboratories that report cases, and then local health departments receive those cases and they do follow-up. So if there's a tuberculosis case that's running around the community, there's often activities that public health nurses and other folks do to try to work with the affected individuals, their families, and their contacts. So these are some of the things that are part of the infrastructure of public health. These local agencies are often embedded in larger health and social service agencies, so they're not on their own for the most part. So that means mental health, housing, other parts of social services are part of the whole milieu, but they are responsible for this public health function. There has also been a division among local health departments as far as their environmental components. So it could be vector control, noise, restaurant inspections, things like that. In some health departments, that function is done by the health department. In other health departments, that may be done by a separate entity. So again, as you're out there interacting with your local government partners, as CivicSpark, you may find the situation and be confused, like, who is that person representing? Is it the health department, the environmental health department? What's the differences? Is this something historical that exists? So just a heads up on that. Then there's the California Department of Public Health. That's where I work. And there is a relationship between the local health officers who get together. It's called the California Conference of Local Health Officers. They get together and they make recommendations. They're bringing all this wealth of information from the field to the state health department, and the state health department can provide statewide guidance and harmonization and be an advocate for them for those activities too. The state health department is a huge entity that has many different programs. I'm not going to dwell on that right now, but it has many of the components for communicable disease, chronic disease control. We also license facilities, nursing homes, things like that. So we do have some regulatory functions as well. Environmental health, family health, child health, WIC. These are all programs that, if anyone's listening from the health department, don't be offended. I don't list. There are so many different kinds of programs that we do, whether it's Black infant health or West Nile virus. You can see, just in those two examples, the spectrum of populations and things that we are involved in. So I'll talk a little bit about what we call the hierarchy of prevention, because I talked about the structure, a little bit about the process of public health and history, and sort of what the overarching strategies are. So I mentioned in the definition that prevention is like the cornerstone of our work. So how do we look at prevention as sort of a hierarchy and as far as a strategy? Well, I know many of the folks in the room here in Sacramento and listening in the field have environmental resources management background. You're recent graduates in these kinds of programs. So I'm showing two pyramids that are really the same in concept. And I did it purposely because I want to show what the parallels are between the work that you have done your training in, the work that you're doing now, and how it really syncs up with the kind of strategies we use in public health, because basically it's the same thing. So in public health, the holy grail of prevention is to do it so that individuals don't even have to think about changing their behavior, and they'll be doing the right thing because it's the easy thing to do. So using engineering strategies is really part of that, or sometimes it could be some kind of legislative remedy, like the banning of a particular pesticide, like the banning of DDT was a way to remove exposure from that. So we can talk about these different strategies of eliminating whatever might be the causal agent behind what's causing the people to get sick, whether it's tobacco or alcohol or any of these other kinds of lifestyle risk factors, or re-engineering cars to make them safer, or designing a healthier urban environment or a rural environment. I mean, these are all part of those strategies. So elimination, substitution, engineering controls, administrative controls, and finally, if that doesn't work, then personal protective equipment. So we've heard a lot about that in the Ebola outbreak, how the nurses and the physicians have to protect themselves and the kind of measures that they had to go to. That's an extreme example of that approach, but when that's all that's available, we got to use it. So anyway, it's the least desirable approach. We can rely on these other ones because there's also, when it says effectiveness of control, there is that hierarchy too. When you don't have to think about it and it's 100% effective, then that's the best situation. So anyway, you know that in the world of toxics reduction, you have a very similar strategy. So you guys probably know about that already. I'm not going to dwell on it, but I just wanted to point out we're sort of kindred spirits in that overarching strategy. Okay, so I mentioned the many different programs that exist in local and state health department, and just to start to draw the link between what the climate and health connections are. The short answer is climate change fits into virtually every program that a public health department has. So in your wanderings in your local setting and you come upon a public health nurse or a vector control person or any number of local, county or municipal public health, environmental health workers, there could be a connection in climate change and health that they're involved in. Maybe not now, they may not even be aware of it, and that's part of what we're trying to do at the state level, is to engage our local health departments and sensitize them to what roles they may have in climate change and health. So this is new to us, it's new to a lot of folks in the field, so we're all working on this sort of in the baby steps together. So these are just a listing of some of the programs. They cross our essential functions, and I won't go through every single one. You'll see this list again a little bit later. Now I'd like to sort of shift gears a little bit and head to this climate change and health equity issue. So I'm assuming the folks have gotten, the Climate Change 101, where we talk about how carbon dioxide is in the atmosphere at sufficient quantities, and its clearance rate is so low that we're stuck with a certain amount of quote-unquote committed climate change. I mean, that's the word that's often used. We're committed to a certain amount of warming. The health equivalent of that is, unfortunately, we're committed to a certain amount of health disadvantage right now. It's not inevitable, it can change, but the basic starting line for many people in our communities is not the same. They are coming to this climate change discussion already burdened by higher rates of disease and injury. So this is one of the things I want to point out, because this sensitivity, and this is, I'm in the Office of Health Equity, we recognize this so that people can propose a solution, but not taking into account where people are at right now may actually have untoward consequences. And we'll talk about that a little bit too, is how adaptation strategies and mitigation strategies may in fact harm health at times. We always are looking for the positive and the co-benefits, but this is something that we want to be very aware of, so that we don't go into the cycles. We're from government, we're here to help you, and then we wind up making people very unhappy. So we'll talk about what that burden of disease is, what the inequities are, what's behind, what's causing those inequities, and how climate change is going to interact with those things. I just want to give a little quote from the Third National Assessment of Climate Change from the federal government, the global program. Climate change will, absent other changes, amplify some of the existing health threats the nation now faces. Certain people and communities are especially vulnerable, including children, the elderly, the sick, the poor, and some communities of color. This is one of these guidance documents that the U.S. government comes out with every few years. It came out last May, and this is something that we're quite aware of. So now you're going to get a whirlwind, folks, of of sort of the burden of disease and injury in California. So this is a little bit of backdrop. If you saw that longevity slide, we were harking back to that first curve going up. That was an era that was dominated by communicable diseases, where a swine flu epidemic could substantially kill hundreds of thousands, not millions of people. We're far from that. We're now in part of what's called an epidemiologic transition, where it's chronic disease that's killing us. Even though we might be afraid of measles and Ebola, those are, in a sense, small potatoes compared to what's going on every day. I think it's something, if you do the math in California, there's about 600 people who die every day of chronic disease, and there's probably less than 10 that die of non-communicable, of communicable diseases. So we are in a profile now where chronic disease like heart disease and cancer and diabetes, Alzheimer's and other kinds of dementia, that and stroke, those are the things that are dominating the picture. And even though you can see in these slides that the good news is that the disease rates and mortality rates are going down incrementally year by year by year for most of the leading causes. Some of them, like Alzheimer's and other dementias, are actually going up. And that's sort of a tsunami that people have talked about as well. But the good news is, in general, the mortality rates and life expectancy are going up. But it's these handful of diseases, you see cancer and heart disease are sort of neck and neck here. I mean, those alone, along with diabetes, I mean, they'll account for 40–50% of all deaths. So just a handful of those things. Now, when you look at the race ethnicity profile of overall mortality rate, well, you see sort of that good news for some of the groups where over time you see the rates are getting better, but the gaps between the different race ethnicities is not really closing all that much. And you see African Americans have a substantially higher mortality rate than whites and other groups. I could repeat this graph for heart disease and stroke and almost all the other conditions, and you'd be seeing the same level of inequity, which suggests, even for a casual observer, if you're not an epidemiologist, like, how could it be that every disease you're seeing the same thing? This is because there's something systemic behind it, and I'll be talking about a little bit of what's behind that too. In addition to race ethnicity, there's many other factors that influence disease rates and their variation. So geographic distribution is very important. So there's big trends from within the state. So you'll see county differences for the state. This is looking at multiple chronic diseases. So on average, about 40% of the adult population has multiple chronic diseases, which in and of itself is a pretty alarming statistic. So we're talking about, heart disease, hypertension, diabetes, things like that, severe mental stress. But when you go within a particular region, in this case, I'm illustrating what's going on with LA County, you see intra-regional or intra-county variation. You can go within municipalities and see that, and I'll show a slide on that a little bit later. So these variations, it could be as short as a few miles away. You could have vastly different living conditions and vastly different mortality rates in different populations. Now I'm going to get to this, so what's driving? What are some of the determinants of health status? Well, one of the big tickets is really basic socioeconomic status. So education, poverty, race, ethnicity, social cohesion, those are some of the big ticket items that contribute to a lot of people's health outcomes. So when you look at the variation in disease rates, in this particular example, it's talking about heart disease. But again, I could show this for asthma and many other kinds of conditions. You see these kinds of gradients where people who have less education, people who have lower incomes, certain race ethnic groups have poorer health outcomes than other folks. So this kind of gradient is part of the health landscape. And when you interact on your local level, you'll be seeing some of these variations as well. Now, there is one approach to framing this, which is really called, sort of the lifestyle approach. When we look at, sort of what's behind this, it's very much an individualized way of looking at things, and I'll talk about other ways of looking at it. It's been observed that if you look at the 3 behavioral risk factors, tobacco, nutrition, and lack of physical activity, those 3 risk factors are associated with those 4 major diseases that you saw in the previous slide. And that accounts for 50% of the deaths in California. So that is huge, because the idea, if you could just intervene on those few things, you'd have a pretty big health impact. So this is illustrating what fraction of the overall mortality is due to these behavioral risk factors. And there are many programs in local health departments and in state health departments that are focused on this. So there's usually if it's a larger health department, it'll have a tobacco control coordinator who's part of a chronic disease effort. So that is one of the intersections here. Also for diet, for nutrition and obesity control, there's it's often embedded in a chronic disease program versus some other part of a local health department. Okay, so I just wanted to give another kind of framing around this issue, which is looking at things in a much more broad sense. This is really what we call the social determinants of health, and say, so okay, you have these behavioral risk factors, but what's behind them? And then you go upstream. That's what we call it in public health, focusing on living conditions. That could be built environment of a neighborhood. It could be economic conditions, so it gets into social policy and economic policy, economic development models. It also gets into much bigger issues of institutional relationships and cultural norms that are very broad, very diffuse, even getting to things like racism and classism and all those things that do have influences and sometimes are imperceptibly getting inside of institutional frameworks and where people don't even realize. I mean, we've seen a lot of what Ferguson, it's been on the news a lot lately, how those kinds of things, I mean, that's sort of the most glaring example of where you have an institutional racism. The Justice Department has made a lot of recommendations, but those are the kind of things that do impact people's lives, and often dramatically. So when we add it all up together, what is contributing to overall health? Well, these socioeconomic factors, and these are based on statistical data and some guesswork. So this is sort of a rule of thumb that most of health outcomes is really about socioeconomic factors. Then these individual behaviors contribute some, as well as the clinical care. So, the fact that we have far better health care now than we did it in the early decades of the 20th century, it is making a difference. But lastly, environmental exposures, the built environment, also make a contribution, but probably on a smaller scale, on average, because you can go to any community and find hotspots of diesel exhaust and other things that might be, changing it for a local condition. All of these things interact. They interact over the life cycle, so it's not just one little exposure. It's also multi-generational. So health behaviors are just like genes are handed down from generation to generation. Community norms for a disadvantaged community are handed down in that neighborhood from generation to generation. So these things are what they call wicked problems, very intractable problems, but they can be solved. So this is just illustrating that a child from West Oakland compared to the Oakland Hills, who as adults could experience a 15-year gap in life expectancy. This is something that starts actually before the kids are born, as far as the advantages, as far as the prenatal environment, the environment in the womb, the amount of stress that the mom is experiencing, but being behind on vaccinations, not performing well in a grade school, dropping out of school, being born into poverty, all of those things that an African-American child in West Oakland would experience that a white child just a few miles away in the hills would not experience, and how that translates as adults into big differences in mortality rates and life expectancy. Okay, so I'm going to talk a little bit now, before we move on to Brooke's part, is really talking about how these factors now interact with climate change. So obviously people who are health disadvantaged, they have chronic conditions, they have mobility limitations, they may be in a nursing facility or something like that. Obviously they have a disadvantage that if there is an extreme weather event, the evacuation, their health, where their medications are being stored could be disrupted. We know that poorer health concentrates in socially disadvantaged communities, that some of the disadvantaged communities actually are in higher risk areas. One of the things that I've been doing recently is looking at sea level rise and where various populations are. But it turns out that 1/3 of the Latino population in Marin County is living in an inundation zone of right now of a 100-year storm. That's a very disproportionate thing. Whereas in Southern California, you see some white populations like around Malibu that are much more socially advantaged. they're disproportionately represented in some spots. So it's not one thing or another, but you have to look at the data carefully. But this could happen. There's also a possibility that some disadvantaged populations have lower adaptive capacity. And what we mean by that, in part, is they may not be living in neighborhoods that have trees, and their ability to plant trees would be an adaptive strategy to lessen urban heat island effects. Maybe they don't have access to air conditioning because they're too poor, because air conditioning is our main cooling strategy. So these are things that may disadvantage as well. There's also a possibility that the strategies and the projects that we are working on in adaptation could actually have an unintended negative effect. So we need to be paying attention to that as well. So these are some of the interactions. So quickly, I'm going to go through what the state is doing. I believe most of you have seen this information before, so I'm going to go through it very quickly. So I'll talk about the state-level activities, Department of Public Health, and what we are doing in the Office of Health Equity on our climate and health team. So this is just relating back to our overall strategies. Mitigation for us, and I'm using the word mitigation the way climate change folks use it, that's primary prevention for us. That's getting carbon out of the atmosphere before it even gets there. I mean, it's just eliminating that at the source. If we can't do that, then we need to shift over to minimizing the adverse effects that we are committed to. So that's the adaptation piece. So that's the language that we use. And just like many disciplines these days, we are a evidence-based and science-based approach to problem solving. So you hear that around state activities, that we want to be guided by the best science. Our public health interventions as well are guided by the best science that we can muster as well, whether it's a randomized clinical trial for some new drug or immunization or other things. So I think people know that what the message is about climate change. I'm going to skip over this. A little bit about what the health impacts are. This is a nifty little graphic that we've gotten from the Centers for Disease Control, and I'll talk briefly about this too. So the inner wheels are really about the physical processes that are driving climate change and the extreme heat and hydrologic extremes. Extreme heat, we know there are direct effects that are going to be experienced and have been experienced. The 2006 heat wave in California is a prime example of that sort of thing, where around roughly 600 people died within a few weeks from excessive heat. I just frame this in a way that we know there's direct effects from extreme weather events like storms and heat waves. We also know that there are ecosystem-mediated effects that will disrupt our vectors and other things, and then there are human systems-mediated effects. So as I go around this diagram, I'll be pointing out those things. So obviously, extreme weather, you can have storms. You know, in Sandy, people were largely drowned and crushed by objects in their homes. That's how that plays out. We know that temperature increases ozone and other air pollutant levels. So there's sort of a tax. All the great work that we're doing on asthma prevention is sort of being undone by the increasing temperatures. And that's just, you know, part of the physics of how ozone is produced. As I mentioned, the temperature precipitation variation, a lot of it is just going to be moving up north and moving to higher elevations, but we're going to be seeing changes in vector distributions. And as I mentioned, West Nile virus is, you know, we've already seen this year, last year, 2014, the largest number of cases we've seen, and now it also coincides with being one of the hottest years on record. So these are things that are likely we'll see in the future. Increasing allergens through pollen. So there's, again, unintended consequences. We can plant trees, but we better plant the right kind of trees to mitigate urban heat islands that won't generate a lot of pollen and make people's hay fever worse. There's many other impacts. I won't dwell on all of them, but I think I've hit the major ones. There are many situations in which human systems will be disrupted. And right now, there's a very substantial number of low-income individuals in California that are food insecure. It runs roughly about 35% of people who are living in poverty or near poverty have this food insecurity. Any disruption to our food supply, whether it's through drought, price increases, availability, nutritional quality degradation, could have big impacts on people's nutritional status, and that is one of the fundamental parts of the social determinants of health, why we've achieved so much health life expectancy gain. Again, I'm going to skip over this pretty quickly. I think you're aware of the legislative framework. You've probably seen this many times. The one thing that you may not be aware of is that the Public Health Department is a full partner in all the statewide activities. I have represented, Brooke has represented, Kathy Dervin, who some of you may know out there, have all represented the state in the climate action team, the cross-sector adaptation group. We've all written the chapters on public health that appear in the California adaptation strategy and the Safeguarding California document. So that is good. We have many great partners at the state agencies, and our health officer participates in the CAT. So just to let you know that we're part of the whole process, and we're very much engaged. And we are also producing documents. Our extreme heat guidance document is one of those guidance documents like the sea level rise documents. So that is one of our public health work group. We run our own, it's called the subcat or kitten, but these are the working, this is the middle management, the state government that's implementing state policy. So Brooke, myself, we are representatives of that kind of middle management in programs that are actually doing this kind of work, and these are some of our work products. So now I'll focus a little bit about member of one of those central functions was surveillance. So we are monitoring heat-related mortality. It's one of the things that we do. And when we are interacting with our local health departments, we can provide some support for their activities. They are doing the same work. In fact, many health departments are actually far more advanced than the state health department. Like LA County is able to upload emergency department visits from the prior day and look at what the patterns are. So we can't do that at the state. So many health departments are really in the forefront of some of these activities. Okay, so work plan priorities, I'll just briefly mention, you know, we're a small crew in the health department working on this. So we have a work plan. We're really prioritizing health co-benefits and communications. Those are the two main areas. We're involved in other things as well, but this is what our work plan is. So in the area of co-benefits, I've been sort of leading up the charge on that, quantifying what the health co-benefits of one of the major strategies, which is really active transportation. We know that a mode shift from biking and walking from cars will reduce greenhouse gases, but the physical activity benefit and the air pollution benefit are things that we need to be aware of. So that is one of the work that I've done. I'm not going to dwell on this, but there are potentially huge benefits. If we were to meet the Surgeon General's recommendations on physical activity, which would be about 20 minutes for an adult every day, your daily exercise, we would be reducing the chronic disease burden by huge amounts. You know, 12% of several 100,000 deaths per year is a big deal. So I've been working now with our regional transportation planning agencies, the MPOs, which you may contact in your CivicSpark work, getting this tool, which is called ITHIM, actually integrated into their travel demand modeling and their modeling efforts. So as they go forward with their sustainable community strategy, so I assume you've all heard about SB 375, that a health dimension could be more actively incorporated into that. So that's some of the work that I've worked on at the State Health Department, and now moving into the translating that research into practice. So we're working with all the large MPOs on this. We've been doing trainings, and we're now at the point where several of the MPOs are incorporating this tool into their SCS planning. Climate change communications, I'm going to hand this over to Brooke for a second, and then back to me, and just to wrap up.
Just to make a follow-up point about what Neil was just talking about the co-benefits model and active transportation, I think we have planned in April a follow-up training, and that is really going to be focusing on the co-benefits and what tools we have around planning and incorporating health into that. And part of one of the tools that we'll talk about is the Climate Action for Health Guide, and we'll be sending those out to you all hopefully in the next month or so. And so climate and health communications is the key focus, as Neil said, and I think we know that there's a lot of efforts that are going on here at the state level, but when you look and talk to people in the general public, not a lot of them are aware of what the real impacts of climate change are to them, and that it is in fact related to health and the efforts that are going on here in the state. And so we think it's really important for us to build on the public health expertise of communication and to really engage more public health professionals in these efforts. And so we have been doing trainings with public health professionals around the state. We'll continue to do that. So one of the efforts that we're working on is really trying to provide resources for local health departments around the state to be focusing on the health messaging and climate change. And so we have a pilot project that's in San Luis Obispo County, and I know the San Luis Obispo members aren't on the phone today, but they are actually involved in part of this campaign. And so this campaign is being spearheaded through the local health department in San Luis Obispo, but it's also through a collaborative that has already well established within their community, that's through their Healthy Eating Active Living group. And so it's their bike coalition, it's their air district, it's Cal Poly, and a lot of other partners. And so this campaign is really focusing on the positive aspects of what we can do to address climate change, and focusing in on really increasing knowledge about the local impacts and what can actually be done in communities. And so we're really wanting to connect their climate action plan to what the health department's already doing. And so we have, they've been linking that one particular example into their WIC classes. So they have classes that are for their WIC population, WIC clients, that we're kind of connecting healthy eating messages to why shopping in a local farmer's market will help address climate change, but also is good for obesity prevention and other things. And so this is really an exploratory project, and we're looking to learn more from that. We know there are a lot of other efforts that are going on around the state as well that we can kind of tie into that. Yeah.
Okay. Thanks, Brooke. I'm just going to wrap up focusing on what some of the adaptation work that we're doing specifically around our BRACE project. This is a CDC project that is going to be funded through the, the next year or two, and it is sort of a health version of what's in the adaptation planning guide. So again, I don't know if folks are aware of that, but the Natural Resources Agency and FEMA and the Office of Emergency Services have come up with an adaptation guide for the state of California, where it really lays out, what are the steps for adaptation planning. This is our version of that, so it's assessing the climate risk, what the health impacts are, understanding what the burden of disease, how it's going to change through the changing climate, assess what interventions are available, and then do the actual planning process. So we're using this model. We are actually using the state's official designations of adaptation planning regions, of which there are 10, and we've recruited 10 health departments in each one of the 10 adaptation planning regions to work with us in the development of specific work products, which I'll talk a bit about in a second. We're focused on extreme heat, sea level rise, coastal storms, and wildfire smoke, and some of the indirect effects that I mentioned earlier, especially around food insecurity, mental health issues as well. So those are the things that we're working on. Here's the map of California with those things, and some of our deliverables, which may be of interest to you because some of them are about to roll out in the next month or so. One is really what we call a climate and health profile report, which individualizes those climate risks, what's the likely health impacts, using downscaled information from CalAdapt. So I don't know if folks are aware of CalAdapt, but it is a tool that takes the global climate models and downscales them now to 7-mile grids, but in short order, they'll be down to 3.5-mile grids. So we're using that information to inform what's happening at the local level with that sensitivity of what is the health burden, what are the disadvantaged populations, what are the adaptive capacities, so that people have some baseline information about climate and health so they can start the planning process. We'll be following it up with much more detailed vulnerability assessments, mostly census tract level maps of individual risk factors, whether it's tree canopy, air conditioning, poverty, sea level rise, inundation, to give people a little bit more information. A lot of this information is available and it's been available, but it's not been all brought together with a health lens. So that's sort of the value that we're adding to that. So this is one of our challenges in doing the BRACE program, is how to engage local health departments, how to involve them in every aspect of this work. We're not delusional in the sense that we think there's going to be a climate change coordinator in every local health department. Often, many of them are struggling just to get their programs going right now. But how to infuse climate and health work into all of their programs to provide them with the basic education and support. That's our first step. That's what's behind the Climate and Health Profile Report, to give them the sort of, technical but not too technical, just sort of informed lay information so that they can start educating themselves and create derivative products, as fact sheets, newsletter blurbs, other things, so that as they go out into the community, they'll be able to be informed on a climate change perspective to the particular work, whether it's WIC, whether it's public health nursing, whether it's epidemiology, whatever. So with that said, I am going to hand this over really to Brooke at this stage. I don't know if we want to have, I think if we hold questions to the end, that will make sure that Brooke has adequate time, because I want to make sure that the activity is done.
About 5 minutes of Q&A. Yeah, I was going to say we haven't had any questions that have come in thus far, but if anyone has maybe some clarifying questions over anything that's been discussed up to this point of time, this would be a great time for you either to raise your hand on the GoToWebinar, or you can type in your question for us now. Usually there's a little lag time.
Don't be shy.
Any questions here in the room?
Yeah.
Put you guys on the spot.
Yeah.
Is there, because we have been talking about health equity, is there a disadvantaged community component to the pilot project in San Luis Obispo?
That's a good question. I would say in some of the messaging that we were doing and the particular focus we had, we weren't necessarily keying in on that in particular, but most of the populations that the health departments work with across the state are focused on disadvantaged communities and unique populations that they're working with. But within San Luis Obispo, and when we were coming up with some of the messages and materials and things like that, we weren't necessarily focusing on that in particular. But when we drilled down further into, like, say, what aspects are we going to focus on in trainings with WIC clients, or going into farmers markets and talking with people, what are some aspects we might want to be covering? I think we were, but I think that that's something that we'd like to strengthen and bring more into potentially being able to do pilot projects in some other communities across the state. So,
yeah. Excellent. No other questions have come up.
Yeah. I'd be interested in hearing when you mentioned about reporting and that the public health departments are required to do certain reporting, and that some people are interested in having them report about some climate change metrics. What kinds of metrics would people interested in having?
Well, hi, this is Neil again. A really good question. There are the exposure pieces, and then there's the actual health outcomes. So you could do reporting on both of those. So right now, heat illness is not a reportable condition. So if it were, I think many things might happen. One is around the education of providers. This would then become an opportunity to educate providers on climate change. And Brooke will probably be talking a little bit more about the different sectors and strategically who needs within the health sector to be educated about climate change. We've done a lot of polling of physicians, public health, in health professionals, and there's a lot of room to improve. And the fact that our physicians are trusted members of our community, they bear a particular responsibility in presenting a particular message. So yes, by having, let's say, heat illness as a reportable condition, functionally just to prevent more heat illness, that will be worthwhile. But the sensitivities and the education, the continuing education in the medical community that could go on around that could potentially have a much broader impact. As far as the temperature effects, I mean, there are very subtle things. Let's say we know that with increasing temperatures, the food supply is in danger, that there's predictions of more foodborne illness related to that. So the report, I mean, right now we get, it's one of the most frequently reportable conditions is salmonella and other kinds of foodborne illnesses. So there are environmental controls that would have to be, levied or leveraged to try to prevent those things. So through the communicable disease reporting or heat illness, there may be ways to extend the climate consciousness to those things. Same thing with the reportable vector diseases to show that as well. Mosquito abatement is another area where there's going to be interactions.
Coming in, so I think we can move.
And I just wanted to mention, I know we covered a lot of things really quickly, and that next week we'll be, you guys will be sending out a message with some follow-up information, and so we can share our website, which has links to a lot of the documents that we've talked about, and also have our contact info and things like that.
And of course, this is being recorded, so for those of you who might have felt like you missed a little piece somewhere or want to go back and review it, we'll be getting out that link hopefully with that email with other resources as early as next week.
Okay, so let me just get settled here. So we wanted to spend time to do an activity with you all and to kind of engage you more, so you're not listening but just thinking about how you could use some of the information we've been talking about when you're out in the community, and thinking about you as AmeriCorps members and CivicSpark members as being ambassadors, like honorary public health ambassadors, and to be able to share our message and to try and engage people in the community to realize that climate change is about health as well. And so just to kind of get our juices flowing, and wanted to have an activity where I hear from you, what do you guys think about when you think about climate change messaging, and are there particular images that come to mind, or populations or groups that are more engaged or not engaged? So I don't know if there are any thoughts in the room first that you might want to share, or...
And just going forward for everyone listening on in your own local area, we will be asking you to participate with the rest of most of today's training. And so please do feel free to either type in your questions, I will be receiving those, or ideally raise your hand if you do have access to audio. We'd love to hear your thoughts, and as soon as you raise your hand, I'll sort of unmute you and give you the opportunity to share your thoughts or your question.
Thanks. So any thoughts? What comes to mind when you think about messages that are kind of out there in the public now around what is climate change, or what people want us to think climate change is?
Sea level rise?
Right. That was polar bear commercials.
Yeah. Yeah. Anything else? Any comments that you guys want to type in, or thoughts that you guys have? Like, do you hear public health messages around climate change, or is it more about
fossil fuel companies must go out of business, and then the environmental movement in general, all of the different pieces?
Yeah, so I think typically the messages that we're hearing are focused from that perspective, and the Public Policy Institute of California has been doing Californians in the Environment Survey for many years, and over the last few years repeatedly they've heard back that that people are aware that climate change is a problem, and that certain populations in the state kind of are more ready to be engaged around climate change, or think that there should be more action than others. And Latino and Black populations score higher in terms of being interested in climate change. And so I think there's a real opportunity for the messaging that is out there now around climate change to be expanded and to draw in more people, and to let them know what's going on in the state, and working on all the projects that you guys are in your different regions are really important. And so I think it's important for you to be ambassadors and to be able to be sharing that as well. So what I wanted to do for the next couple minutes was to kind of share with you examples of some messages that exist, and I know that Jenny had sent out links of these messages to you all, and so I think we'll watch them in groups of 3 because they're very short videos, and then we'll kind of come back together to share what your thoughts are around them. So thinking about like what's the tone associated with the message? Is it positive? Is it negative? What kind of feelings does it invoke? Maybe what audience were they targeting with these messages? And is there any sort of call to action or something that they're trying to engage you to do or to be aware of?
So I think for this, as Brooke just mentioned, we're going to actually take us offline so you all can take some time to watch the different videos. And can we stop? Okay. And then come together after about 3 videos. They're only about 30 seconds, a minute long or so. So watch 3 of them, and then we'll come together, discuss some of those questions. As you are watching them, if you want to be proactive and start typing in some of the questions or some of your comments or thoughts as to those questions that Brooke just mentioned, then we'll come back together, talk about them, and break again. So your screen should hopefully go white soon. Yep. And then now you can access the email that I sent out last night and just watch the links in the order that they are. And now we're going to mute ourselves. Bye-bye.
Yeah, 2.
We'll come back in we'll come back at 11:30. So you have 3 minutes. Ready, set, go. And we're back. Hopefully that gave you enough time to watch the first 3 videos. They're all pretty short. And Brooke, I don't know if you want to read the questions that you wanted them to think about, those, and then we'll take some raised hands, please, as well as any typed questions.
Sure. So a couple of questions that you could keep in mind or answer thinking about, like what was the tone or the feel of some of the messages? Also thinking about what audience were the videos trying to speak to, or do you think that they might have actually reached?
I may have just lost audio. Can we check that, John? Sorry. I just didn't want us to be talking to no one.
Okay, is that connected?
Okay, we're good.
To audio now.
Okay. Thanks, Julie.
And then thinking about what actions may these videos have inspired, or just any other thoughts or reflections that you might have on them. But those are 3 kind of guiding areas. Do we have any thoughts from anyone online? In the room? Yeah. Yeah.
Oh, can you repeat the questions again, really?
So what's the tone or the feel that is associated with the messages? Thinking about what audiences might be motivated by the messages, and then what kind of actions might they inspire, if any?
It seemed to go from like abrasive to like empowering.
I thought the first one was sort of a little bit more antagonistic and kind of more politically charged in terms of the tone, and I think that can kind of deter some people from wanting to get involved in these kind of issues. And the second one was a little bit more kind of just educational and kind of sentimental too, to sort of think about it in terms of nature conservation action. And then the third one was sort of thinking more on like the humanitarian side of it and how to empower people and make it a more human rights issue as well.
Mm-hmm. Yeah, I think that's a really good summary, and I think when you think about who each of those 3 messages were coming from, it kind of makes sense too. The first message was from the Sierra Club, and they're very activist and activism focused and speaking more to their base of members and supporters, and so that makes sense. And then with the Monterey Bay Aquarium, with the second one, their mission is a lot about education and conservation, and so I think they were kind of crafting messages that stayed true to their overall missions and base that they work with. Do we have any other thoughts, or should we move on to the next couple of videos?
Ooh, The coal painting commercial in Monterey Aquarium seemed like the climate issues were silly and almost playful. The I Will Act felt the strongest. Monterey Day 1 was inspiring because it showed we have a choice while other creatures that will be affected don't have that choice to adapt. The second video shows the animals evolving quickly, but then says they won't be able to adapt quickly enough. So it seemed inconsistent, and the message is almost untrustworthy. A lot of the videos wanted to bring awareness about climate change and immediate changes people can do right now, such as recycling or using less energy. So it seems like we're getting a little bit of everything as to what the feelings were of different things. I think we've heard from a few people that I Will Act was a little bit more empowering and strong, but at the same time maybe didn't give quite as many recommendations as to what could be done.
Yeah, and I think already we're seeing we all come with different personal values and interests and backgrounds and things that we're particularly cued into or motivated by. And so that's why after we're looking at these videos and we talk about some of the challenges and the opportunities with climate change communication, one of them is really focusing in on who your particular audience is and knowing that no one message is going to speak to everyone. And that if you only have 30 seconds, it's really hard to explain why climate change is so important, but also to then keep people motivated and to give them some ideas for action. So there's a lot of challenges. Maybe now we can go in and take a break for another, 2 minutes. Should we watch more than 3?
Why don't
let's watch the rest. What do you think?
Okay. So we'll go ahead and break for about 5 minutes, maybe a little bit longer. So plan on us coming back to speak at about 11:40, and then we'll just take time to watch the rest of the links now. We have unmuted you, so hopefully you guys can all hear us again. And same sort of questions, would love to hear the feedback that you all felt or heard or saw with the rest of those videos and audio. And one comment, Act on Climate was the most direct, proactive, and instructive. I think it's the best message for people who are somewhat concerned about climate change but need direction, probably your average Californian. And we also got another comment about the music in the first one. Now, that was a little bit of a weird tone.
Yeah.
Really intense.
Any other thoughts here in the room that you guys wanted to share?
I struggle with the use of the word global warming because I think climate change is not just about global warming, and I think it doesn't fully explain what it is. And I was in Baltimore a couple months ago and there was these snowstorms and it was just all, and I heard some guy say and they say there's global warming, and so it's, to me, I feel like we need to successfully communicate it. We need to move away from that word.
Yeah, and I think that a lot of groups are doing that, and at the health department in the state of California, that is the standpoint.
We got another comment that the most effective commercial was The Beautiful Day in the Neighborhood because it put the viewer directly into the repercussions of ignoring climate change, which I thought was interesting because I actually thought that video was a little snarky and actually downplaying climate change in some ways. So interesting. Again, different audiences get different things. And then felt like the Act on Climate Change was hard to take seriously because felt like there was a disconnect on how big of an issue of climate change is and how simple the actions depicted in the ad were.
I was going to say something along those lines, which I felt like a lot of the actions were, none of them said vote, none of them said get out there and mobilize.
They're all individually focused.
They're very individual focused, and frankly, they were kind of affluent.
Yeah.
Using a reusable water bottle, choosing a cloth sack, that didn't really appeal. The one that had the sort of speaking heads was also the most diverse ethnically, had multiple languages, had the impacts that are happening now. I think that talking about impacts now is huge.
Yeah.
Just saying this is for our kids in the future.
Yeah, so you guys are partially experts on this already. around communicating climate change. And so I think those are really good points. I think one other thing that's interesting that we talk about sometimes when we have trainings around climate and health communications, people bring up the fact, like, you have to call out climate change. And some people, there's varying opinions around that. And so I think even the new Keep California Golden campaign said nothing about climate change, but it's all energy efficiency and energy upgrades and things that are all related to climate change policy and efforts here in California. So
a bunch of responses just came in. Cognitive frames are super important to consider. For the population that does not believe in climate change, many of these messages conflict with their frames.
I also thought it was interesting, I read a lot that organizations like the American Lung Association and people like that are really trusted messengers, and so that they're really more likely to believe something from the Lung Association or from their doctor than anyone else. So I thought that was clever to have, that it was from the Lung Association.
Yeah, and there was polling done after Prop 23 that said that because of the public health messengers, they were really seen as trusted people in the community, and I think that comes over and over again in us talking about how public health has had that standing for decades and looking at what happened around tobacco and changing the public opinion around that. And so I think there's really a benefit for us to be more engaged in terms of climate change communication as well.
I just got a response that actually basically says the opposite, and it's saying that they had a negative response to that ad campaign against the prop because it took such a negative tone and it didn't make her want to listen because she didn't maybe understand that she understands that many political issues are complex and they made it look so black and white. So she discredited them right away.
Okay. So do we have any other comments, or maybe we should move forward?
Yeah.
Okay. So what I wanted to share with you all is just some highlights of things that we've already kind of brought up in our discussion about why climate change is such a complex issue to communicate. I think most of them we've kind of already hit, but that climate change has been politicized even though we know the science is there, and that we've kind of taken the standing that we're not and we've done this in the pilot project in San Luis Obispo as well, that we're not going to debate the climate science and we're not going to engage in that way. We're coming from a standpoint that everybody already believes that climate change is in fact happening, even though I know there are some communities that some of you may be working in where there's political leaders that don't necessarily believe that, and that is indeed very challenging. But that's where focusing in on some of the co-benefits and things that communities are already doing, that even if you don't believe in climate change, if you take those actions, they'll benefit the community, that's one approach to kind of address some of those problems. So here's a list. I know we're getting close to running out of time, so we don't need to go through the whole list. You can see, but one of the other things we talked about is that climate change is such a big, overwhelming issue, and you know that it's happening everywhere, and it's often communicated as global warming, and so that's taking it out of the local context, or seeing how it's going to immediately impact you or maybe your family, or that how is using a reusable bag really going to impact sea level rise in some place. Like, there's just a disconnect between the actions of the intensity or the immense problem that we're faced. And another thing is that we're not suffering from a science deficit disorder, so it's not necessarily that people don't have enough information, but it's that it's not connected to people's lives. So I wanted to share some key communications lessons, and as a follow-up, we'll have a couple different resources that I can share with you guys that kind of summarize some of this as well. And so one thing we brought up was really to know your audience, and we've talked about this already, that it's really important to know what kind of message will resonate with what particular audiences and what messenger would best deliver that, whether it's looking at having a public health nurse or a doctor like the new American Lung Association's campaign is doing, or if it's having a mother speak to other mothers. And another aspect is to really and we mentioned this already too, is kind of consider and respect people's underlying values or what's most important to them. So if you're in, say, San Luis Obispo County, where there's a very large agricultural community, maybe focusing in on how climate change might be impacting jobs or impacting what kinds of fruits and vegetables are available, or looking at, okay, well, we should be proud of the fact that we have so many farmers markets and that we're really known for that, and that we can continue to share the importance of that with other communities to help increase climate change mitigation actions. Another point we talked about is making climate change local and now and personal. So I think that kind of summarizes overall some of the key things that are important to keep in mind. And focusing on solutions and win-win. So instead of having people feel defeated or overwhelmed by climate change, trying to think about what are some of the connections that are good for climate change, but also good for other reasons. So we're focused on the ones that are around public health and looking at obesity prevention, chronic disease prevention, getting more active transportation, which has mental health benefits, but there's also economic benefits to different climate change actions as well. So keeping those in mind and knowing your audience and which ones might speak to them the most. And really focusing on, okay, well, climate change is happening in the future, but the people in the future are our children and people that we care about and that we're connected to. And I think one aspect that can be challenging to do sometimes is being able to use stories. So I know in a lot of different communications fields, there's more of a push towards storytelling campaigns or really using stories to engage people and to really see how issues are affecting people on the ground, and using that more than graphs and facts and numbers and figures. And that's a key lesson that we've learned. And these were just some points I wanted to share, that we had done focus groups around the state in English and Spanish, and that from the community health leaders that we spoke to, we heard a lot of the same things that the experts were saying around lessons to be learned around climate change communication. And that one thing was that people really think that it's important to connect messages to things that people can actually do, and that just raising awareness isn't enough. We need to figure out how to mobilize communities and mobilize other people to be engaged more around climate change. And so this slide was just to show that public health has had a lot of success in moving public thought and action in the past, and that we really hope to be able to be providing more leadership on this in the future. So we have 5 minutes left, and we wanted to do an activity with you to kind of have you come up with your elevator pitch. So given what we talked about today around climate change and the health impacts and connecting it to people in your communities, we wanted to have you think through what would your elevator pitch be when you're out in the community or working with your particular stakeholders on your projects. Kind of how would you speak to your specific audience, and make it local, make it personal, and have it connected to something that's really critical or on people's minds today or in the next few weeks, and how you would really add in the human or the health dimension. So not just focusing on sea level rise or looking at how temperatures are going to increase, but really talking about how that may impact people and their children and their families. So
I think that what we'll do is give this as a little bit of a homework assignment, and what I would love to see is actually have someone, in whether or not it's someone who will actually be on the call and can sort of give us the elevator pitch, or if you want to just get it to me in advance. During the April training, the first thing that we'll do is start off with an elevator pitch from each region. And some of you might find within your regions that you need multiple elevator pitches. Some of your programs have different audience, or some of your projects have different audiences, and so it might be worthwhile. How do you put together an elevator pitch for this specific project versus the other project that you're working on? Go ahead.
And if any of you want to get really creative and have an idea of like, oh, well, I want to come up with what a blog post could be, or add some sort of visual element, or want to get more creative with it because you felt really inspired, then I encourage you to do that, but maybe you won't.
We'll make it as big as you want to make it. So we've been mentioning that we'll be following up with some other resources that I'll be emailing you next week. I will also be at least sending this slide so you have the instructions as to exactly what we want you to sort of think about putting together before the April 23rd training. And again, try to figure out who on your team, if you want to do it as a group, that would be fantastic if you're all in the same room during April 23rd, but ideally we'll have one person from each team who I can unmute and they can share their elevator pitch or their blog post or whatever project that they end up doing at the start of that webinar. Sound good? Any questions? No. Excellent. Well, any final things?
I don't think so. I want to say thank you for having us here, and we're glad to get to connect with you all. I'm looking forward to coming back again in April.
Thank you very much for being here and making time. We're really, really appreciative of this and can't wait to see April as well.
Okay. Thanks.
Thank you. We will talk to everyone soon. Bye.